you know, that those two gentlemen that we were speaking about are just two of the older adults with mental illness and cancer that our team has been caring for over the past year, many of whom face many challenges. And when we think about this and the unique challenges that older adults are facing right now, especially those with cancer, we just feel so lucky to have an awesome panel who will provide diverse perspectives on how we might engage older adults with mental illness and cancer and their caregivers. And in particular, talk about how people might be reached during COVID-19. So we have three panelists: Dr. Ryan Nipp, who is an oncologist in the Cancer Center who focuses on GI cancers and geriatric oncology and equity; Kelly Trevino, who is a psychologist and wonderful researcher in implementation science and evidence-based interventions for older adults with cancer and for their caregivers; and Claribette Delrosario, who is a program director at wonderful ASAP, who's really leading an elder mental health outreach team and doing wonderful work to get care to them and think about the practical needs that they might be able to assess and address. So I think it'll be a great opportunity to learn from all three of them and from our discussant, Feyza Marouf, who's a geriatric psychiatrist who will join after the panel. So I'll turn it over to Ryan Nipp.
Thanks so much, Kelly. I will try to share my screen. Let's see if I can share my screen. Let's see. Well, it's not letting me share screen. Let's see. There we go. See if that works. Can everybody see this? Okay. Let me know if you can't hear me as well.
You sound good.
Perfect. So I'm asked to talk about the intersection of geriatric oncology and mental health. I'm honored to be here. Thanks so much for having me. I have limited time, so I will get started. No disclosures. I wanted to talk a little bit about an outline. I've got 4 points that I'm going to run through, and I'll just touch on these briefly. The fact that cancer disproportionately impacts older adults. The fact that older adults with cancer often present a unique set of challenges for the clinicians caring for them. And geriatric assessment can help address the distinct geriatric needs of older adults with cancer. And then lastly, I'll touch on the need for novel care models, but mainly that point I will pivot to talking about the COVID issues that are affecting our clinic right now. So first, the fact that cancer disproportionately impacts older adults. I wanted to start with the case. This is an example patient. This isn't the exact details just to protect privacy. But as an example, I care for a patient in her 70s, say 77-year-old female with pancreas cancer. And I met her on the inpatient ward, which is when she was hospitalized at Mass General. At that time, the surgeons had thought she may be a surgical candidate and had taken her to the operating room to try to remove her tumor. Unfortunately, at that time, she was found to have metastatic disease. But I think we'll go through her case throughout this talk, and she brings up a lot of interesting points. And she also brings up something that happens quite common in my practice, this being an older adult with cancer and a GI cancer specifically. So just touching on the fact that cancer disproportionately impacts older adults, I have a slide here showing the number of cases per year for individuals with cancer and the percent change per year for individuals with cancer in 2 different charts. And just to touch here on the left chart that talks about the number of cases per year, what this shows is that the older population, which often is referred to as older than 65 years old, although that's becoming younger and younger every year, you can see in this chart that the older adults over 65 are highlighted in gray, and that the number of cases per year, the older adults are by far the most common population that we see in clinic. And then I think this one on the right is also interesting, where it talks about the percent change per year, which tells you that the older adults over age 65 represent the vast majority of the patients we're seeing, and it's also they are growing at a greater rate than the other age groups, which if you look on this next slide does a nice job also of illustrating this point. This is a paper from New England Journal in 2018, which shows across all these different age groups. So they broke it down by greater than 85, age 75 to 84, age 65 to 74, and then under age 50. And you can see that green, purple, and blue, which is the age 65 and above bars, make up the vast majority of the population that we see in clinic. And you can also see this does a nice job of showing how that is an exponentially growing population. So this is the most common population that we see in clinic, and it's only going to become more and more common. So then moving on to just at the next point, whenever we were caring for Mrs. KP, questions soon arose regarding some mental health issues and then her cognitive function. She has a wonderfully supportive husband. This picture that I'm showing here is of walking shoes because she always came in with her walking shoes on. She and her husband go for a walk every day to try to stay active. But he made it clear that there has been some issues in the past with major depression that he's worried about now that she's got this incurable cancer diagnosis. And then it was also interesting while she was on the inpatient ward, a lot of the healthcare providers were concerned that she may have some issues related to her memory, and how strong those are and how long they've been going on, we weren't aware of, and it hadn't really been formally evaluated. So just moving into that next phase of the talk, older adults with cancer present a unique set of challenges for us as clinicians. And so this slide does a nice job of just exemplifying that older adults with cancer have a higher risk for experiencing toxicity related to treatment. So what this shows in these two different graphs, so this is several studies from large clinical trials in the 80s and 90s, and they broke patients down by age group, 50, 51 to 64, and again, 65 and above. And you can see in this first chart here across all of the age groups and across all of the studies, the older population was more likely to report toxicity. And then that chart on the right here, which is also concerning, is treatment-related death, which is one of the worst outcomes we could ever potentially imagine. And you can see it's quite rare that we see this, but despite that, you can tell that here, based on this chart, that the older population is by far more commonly experiencing that adverse outcome. And why might that be? I just listed here a few of the unique challenges that we see in geriatric oncology. There's many more than this, but I'll touch on some of these throughout the talk, those being physical function, comorbid conditions like heart disease, kidney issues, cognitive issues like memory that we're dealing with Ms. KP, polypharmacy issues, symptom burden, which can be a different symptomatology that you see in older versus younger patients. There's nutritional issues and loss of muscle and ability to stand from a chair and risk for falls. And then there's social support needs that we'll talk about a lot throughout the morning. So just getting back into our patient, how would we potentially address all of these different unique aspects of the care for Mrs. KP? There's plenty already to talk about when you're dealing with a cancer diagnosis, let alone all of these other competing issues. And so that gets into the fact that geriatric assessment is a very helpful tool that could help address the distinct geriatric needs of older adults with cancer. I just wanted to highlight here on this slide that we have a very fantastic geriatric medicine department that delivers multidisciplinary care in the context of each individual's functional and psychosocial situation. We have this, we are lucky to have this at Mass General. Most academic health systems have geriatric departments. How embedded they are, how integrated they are within the cancer center is still being worked on. And so that's something that I'm very passionate about, is trying to bring more geriatric medicine specialists into the care of older adults with cancer. And this is something that geriatricians are the most experienced with. This is what they spend their time training on. They're very specialized in conducting a comprehensive geriatric assessment. And what that entails is different domains that they're assessing within a given visit. And this just does a nice job on this slide of exemplifying or illustrating all of the different things that a comprehensive geriatric assessment may focus on, those being physical function, medication management, comorbid conditions, psychological issues, nutrition, physical symptoms, social support needs, and cognition. And then there's been some specific research within the oncology world of how could we incorporate comprehensive geriatric assessment in the world of oncology. And it's definitely something that makes a lot of sense for our older adults, but how could we actually do this in a given clinical practice? And so this is a nice slide here that just shows some of the different domains of the comprehensive geriatric assessment that we could be doing within our cancer centers. And this, I think, also does a nice job. It's a little bit smaller font, but it gives you some examples. So for functional status, we could be evaluating patients' gait speed or their activities of daily living. For their cognition, we could be doing a mini mental status exam or the blessed orientation of memory scale. For social support, simply asking the patient and their loved ones, how much support are they getting at home. For physical performance, looking at actual subjective and objective measures such as gait speed and a timed up and go test. For psychological status, there actually is a tool called the Geriatric Depression Scale specifically developed for older adults. And for nutrition, asking the patient about weight loss, and then also there's a tool called the mini nutritional assessment that if you were to Google, it's a very helpful tool. And then I just wanted to touch on just a list of people or an example of who may be important in the care of older adults with cancer. There's a lot of different members of the team that can become an important role in the care of an older adult. And so here's just a list. This is certainly not exhaustive, but just a list on the top of my mind. I've got that at the top here. I'm biased, but the oncologist is going to be a key member of the team. A pharmacist could be helpful in helping with polypharmacy and looking at interactions with different drugs that a patient may be taking. Of course, the caregiver and the family members that we'll talk about more throughout the morning. Social work, psychiatry, and psychology, or the psychosocial domains, are going to be crucial for older adults with cancer. Nutrition and dietitian support can be incredibly helpful. Again, I've got listed here palliative care and geriatrics. Those are incredibly helpful, and those can be a talk all on their own. Physical and occupational therapy can be really helpful for these patients to help with their physical function as well as their getting around at the home. And then the primary care provider will be really important because they know the patient often more in depth and for a longer period of time than the oncology team. So getting their picture of how the patient has been doing can be incredibly helpful. And I just wanted to touch base here on this last point, the fact that older adults with cancer may benefit from novel care models. We're doing a lot of work actually with Kelly and here at the Massachusetts General Hospital on how can we embed geriatricians in the clinic, how can we make geriatric care more available to older adults. And I would love to talk about that. That's a whole talk on its own. But I think right here is where I would pivot and talk briefly on how things are going with the COVID pandemic at Mass General and for our older adults specifically. And I just wanted to talk briefly on a few points of what may be happening right now as older adults are experiencing this. So what we're doing currently, I think a lot of hospitals have done this where the COVID pandemic has been hitting hard, is we are limiting the amount of people that can come into the health system. So for example, if a patient comes to clinic, we're asking that only the patient come into the clinic. Their loved ones and family members and social supports are now no longer able to come into the clinic visit with them. And that creates a whole set of challenges, especially for the older adult population, where they often rely on their loved ones to get around the hospital system. This is a big healthcare system and tough to get around, let alone whenever they're actually in the visit with their loved one. They can help with relaying some of the things that have been going on at home. They can help with remembering things and being the eyes and ears for the patient. And as the clinician, it's also helpful to always have the point of view of their social support and their loved one, which we are now not getting as much, which reminds me of the next point I wanted to make, which is we're now relying a lot more on technology in clinics. So we're doing a lot more virtual visits and a lot more phone visits with patients. And there has been some data in the literature showing that older adults with cancer are less likely to enjoy those visits and less likely to engage in those visits with technology. And so that's something that we've had to pivot and do a lot more work as far as how can we engage older adults with these phone and virtual visits. I've been very pleasantly surprised thus far. It has gone actually quite well, but that's something that also requires more work and is a new challenge that we didn't expect with internet access and phone access and being able to contact the person and just not being able to see them and not actually having that touch point that we're used to having every week or every other week when we're seeing patients while they're getting their chemotherapy. And so there's a lot of new challenges that we're facing, and those are just a few examples, and we'll get into more throughout the morning. And I think that would be the last point I wanted to make, just kind of highlighting here the patient, just to take it all home. She has done quite well with her treatment, actually. She has proven to me that even despite cognitive issues, that she can continue to receive treatment and do well. And then we are continuing to move throughout this unexpected pandemic, taking it day by day, but she's done a really good job, mainly because she has such incredible social support help with her husband and getting the phone visits and being able to do the virtual health. Thank you very much. And just the last slide here of the Cancer Outcomes Research Group that I work with at Mass General. Everything I do is thanks to this incredible group, and Kelly is a key member of this group. So thank you very much for having me.
Ryan, thank you so much. You're such a leader in geriatric oncology, and we really appreciate your time this morning and how thoughtful you're being about meeting the complex needs of older adults. I can't wait to see the results of your collaborative care trial, and I love getting to care for patients with you too. Thank you so much for your time. And we'll turn it right over to Dr. Trevino.
Okay, great. Let me see if I can share my screen here. We were having a little bit of tech difficulty earlier, so give me a second. So are you able to see my slides? Okay,
Yes,
great.
I see that.
It's a real honor to be here with you this morning and to talk with this wonderful panel about the unique needs of older adults. I'm going to be talking about a particular problem around implementation or the provision of services to older adults with mental illness and cancer and their caregivers. Since we are remote, this is what I look like, generally speaking, just so that you have a picture in your mind. I don't have any financial relationships to disclose here. So I'm going to jump right in. And again, the particular problem I'm going to be talking about today is the problem of what we call implementation, or the provision of services, getting services that we have to the patients who need them. So I am a clinical psychologist by training, and in clinical psychology, we have various types of therapies that we know based on the research work. So therapies like cognitive behavioral therapy and problem solving therapy. But we have a big problem in our field in that these treatments don't often reach the people who would benefit them the most. And so this is an implementation problem, that we know these techniques are helpful, but we are not as good as we could be about getting them to the patients who need them. And we can see a similar challenge in the care of people with cancer and mental illness, where we have good cancer care. We have, to some degree, mental health services available or caregiver support services. But it can be hard sometimes to get these services to the people who need them. And that is a lot of what this group clearly does, and does very well. But certainly there are many areas in the country and across the world where there are many challenges to implementing these services or getting them to the patients who will need them. So as our team was thinking about this problem, we realized that we needed to learn a little bit more about what was happening. What are the barriers to providing these services, and how might we think about addressing those barriers so that our care is better? So we conducted a project called a consensus conference workshop to try to answer some of these questions. And we followed a particular model that came out of the Cornell Institute for Translational Research in Aging, their research practice consensus workshop model, which is a mouthful, and I'll just walk you briefly through the different steps. And on the slide here, I have a link to their workbook for how to use this model, and I can send that out later if people are interested. But the first step in this model is really to pull together a panel of diverse stakeholders. And I know I'm preaching to the choir here in terms of the importance of having many stakeholders and many voices at the table, but I think this is something that can be easy to forget about. And so these are pictures of our stakeholder panel. They include researchers and clinicians, people in leadership positions, a patient advocate, a caregiver advocate, an oncologist. So again, just a range of people with expertise who came together to help us figure out how to run this consensus conference. And so in brief, what we did is we brought together a larger stakeholder group representing all of the groups I just mentioned: patients and caregivers, oncologists, mental health providers, community organizations. And we talked together about what are the barriers to providing mental health, psychological services to older adults with cancer. And once we identified those barriers, talked about strategies for improving implementation of those services. So once we had a sense of what we thought the barriers were, how could we work around those to improve our care of older adults with cancer and their caregivers? And after we had that large stakeholder group, we looked at all of the ideas people generated, and it was pages and pages of wonderful ideas. We brought together a smaller group of stakeholders who helped us sort of organize those ideas, and using different kinds of data analyses, found themes that we thought might be helpful not only to us, but to the larger field, larger groups of people, other institutions who might be trying to improve the mental health services provided to older adults with cancer. So what did we learn, and what might be some things for you to think about if this is an issue that you are working on or thinking about at your institution? And you know, we don't always have time to run a consensus conference and have large group meetings and small group meetings, and that's okay. What I'm going to show you next is how what themes emerged for us, and what questions you can think about yourself or with your team to try to better implement these services. The other thing I will say is that in the context of COVID-19, the answers to these questions might be unique and a little bit different, and that's certainly important to consider. So when we were organizing our thoughts around this, we considered a couple of different areas or topics. So the first topic is, what are the interventions that we're trying to provide? What are the services that we're trying to provide? Who are the people who are involved in the provision of those services? So that's the people with cancer and their family members. That includes providers, both on the oncology team and the mental health team. What is the setting in which these services are being provided? And that includes the inner setting, like the clinic, and the outer setting, like the larger economic and social context. And then what is the process by which we are implementing or providing those services? And this framework, for lack of a better word, helped us think through all of the different themes that came out of our conference. So when it comes to the area of intervention characteristics, I picked out a few of the barriers and strategies that we came up with. This is not an exhaustive list, but the point is to just give you a sense of some of the issues that came up for us, to trigger maybe thoughts that you might have about your own particular situation and questions you might think about for yourself. So one of the themes, for example, was that older adults and their caregivers may have feelings of stigmatization toward mental health services, and that might be a barrier to their participation. And so we came up with strategies for really normalizing distress in the context of cancer and taking a strength-based approach to mental health services. Another issue was that many interventions are not specific to older adults. And so how can we develop interventions that recognize what we call the double whammy of cancer and aging, which is really a triple whammy for people who are also dealing with mental illness? So thinking about what kind of barriers might exist related to the interventions you are interested in providing. For the individuals, oops. Are you still able to see my slides?
You see your cover slide?
Okay, let me try to pull it up again here. Just closed out on me. If I can't get it up and running soon, I will defer, because I know we're short on time and I don't want to hold us up. What are you seeing now?
Let like you just need to hit okay and you should be okay. There, looks good.
Okay, sorry about that. We were having some tech problems earlier. So when thinking about the individuals involved, these things are not going to be new to all of you, but caregivers have a lot on their plate. And so we talked about the importance of separate treatments for caregivers. Another thing that often comes up is many providers don't have training in how to treat older adults specifically. And so are there strategies for integrating basic training information for providers in working with older adults? So again, thinking about who is involved in the interventions that you're trying to provide and what might be ways to address the barriers they may face to treatment. For the setting, and these are things that are obviously very important, and Ryan alluded to some of these, the location of mental health and oncology services. So if the mental health treatment team and the oncology treatment team are far apart, that can be a real barrier to care. And certainly we see that with COVID and the importance of considering things like telephone and video delivery. Another issue can be poor communication between oncology and mental health teams. And clearly this group is doing a lot of work in that area, but the importance of really having a structured strategy for promoting communication between those teams. So thinking about what characteristics in your particular setting might be barriers to implementing these services can be a really helpful thing to think about. When it comes to the outer setting, these barriers can really range. So one barrier that our group came up with that again, this group is very good at is that hospitals can become very siloed from community organizations. And so strategies for building partnerships is really important. There can also be policies that get in the way. So oftentimes telephone mental health services are not reimbursed by an insurance company, which can be a real barrier to reaching people who may not be able to come into the clinic. So what are the larger sort of outer setting barriers that might be challenges for you, and are there ways of overcoming those? And then finally, the implementation process. So oftentimes we have a service or an intervention that we want to provide, but may not think through ahead of time how to actually integrate that into our oncology care. And thinking ahead of time about that and developing a detailed plan, even if that plan changes over time, can really help overcome some of those implementation barriers. And then of course, making sure that all relevant stakeholders are engaged when thinking about how to implement a particular intervention or service is important, because each stakeholder group is going to be able to identify different barriers and solutions. So in conclusion, just a few take-home messages that we learned and hopefully will be helpful for you, that it's important to take time to understand the problem, and that as a part of that process, all relevant stakeholders need to be included. We found it helpful to use a framework. When I use that word, I'm just referring to the fact that we thought about intervention characteristics and characteristics of individuals, the inner and outer setting, just to help us organize our thinking and be strategic and comprehensive. All of you know that this is hard work. So if there is low-hanging fruit, start there, get some success. And of course, it's going to be an iterative process where you try something, you revise it, you restart, and of course, most importantly, keep going. Because what we're trying to address is this issue of having resources that aren't being provided to the patients who need them, and really eliminating those barriers so that those services are getting integrated. So again, just a few acknowledgements. Thank you so much for inviting me, and I look forward to the rest of our discussion.
Thank you, Dr. Trevino. It's wonderful to hear from you, and really appreciate your thoughtful comments about how to get interventions to the people who need them. We're excited to learn from Claribette, Delrosario.
Hi everyone, it's a pleasure to be with you today, wherever you're watching this. My name is Claribette Delrosario, and I'm the Counseling and Support Services Director at Ethos. I'm going to talk to you about one of the programs at Ethos that is trying to address mental health concerns during this COVID-19 pandemic. Let me first talk about Ethos as an ASAP. An ASAP is an Aging Services Access Point. That's a one-stop shop for elders and caregivers seeking long-term care. And it's funded and regulated primarily by the state. There are 26 ASAPs statewide in exclusive geographic areas, and they are private, nonprofit agencies with governing boards made up of at least 51% of persons age 60 or older and appointed by the local councils on aging. ASAPs provide direct services, including information and referral, interdisciplinary case management, intake, assessment, development and implementation of service plans, monitoring of service plans, and reassessment of needs, and protective services that investigates abuse and neglect of elders. Here is a list of the ASAPs across the Commonwealth. Again, they're in exclusive areas to prevent competition. Elders are assigned to an ASAP based on their location. I also want to make note that some ASAPs are also AAAs. AAAs were established under the Older Americans Act in 1973 to respond to the needs of Americans 60 and over in every local community. AAAs provide a range of options that allow older adults to choose the home and community-based services and living arrangements that suit them best, and make it possible for older adults to age in place in their homes and communities. Here you'll see a list of services offered to demonstrate the width of an ASAP's reach. There's laundry services, companion services, behavioral health counseling, and so on. Ethos is the ASAP that covers the southwest region of Boston, specifically the neighborhoods of Jamaica Plain, Mattapan, Hyde Park, Roslindale, and West Roxbury. We serve over 2,000 low and middle income seniors. Again, because we're designated as an ASAP, we're state funded and state contracted. We also have a number of private funders who help support our programs. Beyond our home care services, we have a number of complementary programs that promote interagency collaboration, including senior care options, PCA, health and wellness courses, money management, and mental health services, including the Elder Mental Health Outreach Team. Our Elder Mental Health Outreach Team, or MHOT, is a program whose intervention is tailored to older adults 60 and over living in the city of Boston, dealing with underlying mental health needs that impact their ability to maintain autonomy and some degree of independence in the community. We have targeted outreach for people who identify as lesbian, gay, bisexual, and older adults of color. We often see people who have depressive, delusional, general anxiety, personality, bipolar, schizophrenia disorders, and PTSD, and suicidal thought, non-suicidal self-injury. In addition to these mental health diagnoses, MHOT sees older adults dealing with Parkinson's, stomach cancer, breast cancer, spinal stenosis, and others. We also, in MHOT, provide social work services and emotional support. Quickly, I just want to make note how somebody might make a referral to an ASAP or AAA in the Commonwealth. The referring agent or the concerned party can call Boston Elder Info or 1-800-AGE-INFO. Specially trained workers will provide you information for every step of this process. We're in the middle of a pandemic, and it's a time where there are so many unknowns. It's unclear if or when things are going to go back to normal or whether there is a new normal. In MHOT, we work with people who have mental health and behavioral health concerns. Right now, we're regularly making contact with all of our clients to assess their level of risk while living in the community, and we're seeing some challenges over and over again. We're seeing that although protections for housing are put in place right now to prevent eviction, we're seeing that evictions can still happen if the person is a danger to themselves and need to be in a higher level of care, or if they're a danger to staff and other residents. We're also not getting in contact with everyone, so we have to conduct face-to-face visits to conduct wellness checks and to better assess our client. We're finding people are putting off essential medical appointments for fear of going to the hospital and contracting COVID-19. We're seeing challenges with engagement because delusional thinking, paranoia, depression, or anxiety may get in the way. And our level of assessment over the phone is not as comprehensive as face-to-face contact. This concerns us when we cannot see as much of the client's current situation as we would like. But with these challenges comes ideas to better prepare for outcomes. Based on our experience now, we see that there is a need to plan 3, 6, 9 months ahead. Particularly, we need training for trauma response. We're working with local colleges to provide grief support groups for clients and staff. We feel that there will be complicated family dynamics in the coming year as a result of the recession that will follow COVID-19, and we'll want to address that. We will need to deal with unresolved grief due to COVID-19, and we will need to increase our capacity to serve non-English speaking elders. Now, I just want to leave you with this last slide for contacts that might be important as you walk away from this webinar today. And so I hope that this information stirs up conversation about what we can do to support one another and promote interdisciplinary collaborations to hold our clients during this pandemic and increase the welfare of our elders. Thank you so much for your time, and I turn it back to our moderator.
Thank you so much for those incredibly helpful resources, Claribette. Really important to know about. I took a picture of how to refer, and I'm so glad that you're sharing them. I'm going to turn it over to our discussant, Dr. Feyza Marouf.
Thank you, Kelly. And I don't have a picture, so I'm going to be a live talking head as this part of the presentation, and hope to be able to raise some questions that I had been thinking about, but also some that are coming up from our question and answer section, and also from our chat. I want to thank everyone again for presenting, and really wanted to think about, sort of given the current conditions of COVID-19 and the impact on cancer care and geriatrics and mental health care, what your thoughts are in terms of how things are changing. Who are the patients that you are most worried about right now, and how do we balance the changes in care that are occurring because of the virus with our recommendations for treatment. Certainly we've seen, that treatment can lead to immunosuppression, risks of complications, and thinking about, again, sort of how that impacts, how the worries about the severity of COVID when it occurs, how that impacts our population specifically. So, so how are all of you reconciling that in the midst of the patients that you're seeing and the families that you're working with?
I'll start briefly. I would say I've thought a lot about this. I knew this was going to be a question, and so I think it's largely the population that you're worried about already, the population that doesn't have as much social support, as much family help at home. That's going to be a group that's incredibly high risk right now because it's hard to get into the cancer center anyways. Now we're avoiding coming into the cancer center. It's hard to deal with your cancer anyways, and now you're having to do it on your own without coming in to see the oncology team as frequently. And when you do have issues, you're having to do a lot more telehealth, and that's putting a strain on our, again, call center is not fantastic here. And so that sometimes it's hard to get in, and then you have to wait, and you're not feeling great. You're on your own anyways, let alone everything that's going on in the world with difficulty getting groceries, having to wear a mask if you do go and get groceries, the uncertainty and the anxiety around everything right now. You're already dealing with a very tough anxiety producing illness, and then you deal with what's going on in the world. I can't imagine how these people are, the stress that's being placed on them.
And do you find that the conversations have changed, right, in terms of like becoming more explicit in those concerns about the COVID and sort of what that might mean in terms of impacts on treatment?
Probably 90%, 95% of my visits have been telehealth visits the past month, and the 3/4 of the visit is talking about how are we doing in the health center, which is so nice, and people are incredibly gracious, as you would imagine. But it's just nobody really wants to talk about how they're doing. It's like, what's going on in Boston? What's going on at Mass General? What are you guys doing about the COVID? So it kind of sucks all the air out of the room, and it takes up the entire conversation. That's one issue. And then, yes, we move into a lot of questions about what could me or my loved one be doing to avoid getting this. And I hate to be a broken record, but it's exactly what everyone's hearing on TV. It's the washing your hands like crazy, avoiding touching your face, and then if you go out, having a mask. I mean, these are basic, and that's real. There's no other tricks besides that, avoiding contact with crowds and groups. And if you could send somebody else to the grocery store or have it delivered, that would be ideal. Using wipes when you do go out to wipe everything down, possibly with disinfectants when you get home. Things like that. There's no real, I can't think of anything specific more than that.
Great, thank you. Kelly, Claribette, any other thoughts about sort of who are you worried about most, and how has COVID impacted those conversations?
In the elder mental health outreach team, sometimes we receive referrals from the protective services program here in Boston. And oftentimes it's very difficult to engage with those folks because we can see as the concerned party or the referral agent that this person could really benefit from additional services to support their emotional well-being and physical well-being. But then when we finally reach out to the concerned person, they're finding that, no, I don't want anybody in my home. I don't want to talk more about this. In fact, it's even, it becomes much more challenging since they'll use, I don't want to see anybody because I don't want to get COVID-19. I want to suspend all services, in fact, because I just don't want to be interacting with people. So we're concerned about, even more social isolation, even deeper isolation that can impact their well-being and physical well-being.
Yeah, I agree with everything that that has been said. I think a situation like this, like Ryan said, just exacerbates existing challenges. I can say I'm seeing a lot of anxiety, as you can imagine, and people with cancer you know, the comorbidities that often come with aging are well aware of their risk should they get COVID-19, and that is very frightening for people. And so when they live alone and they have to go out for groceries, or they live alone and they have to go to the pharmacy, that triggers a lot of anxiety. The other thing I'm seeing is that people who have a history of trauma, even if they had gone through treatment for that trauma and were managing it well prior, that COVID-19 is really triggering a lot of the traumatic reactions they had before. So we see a lot of folks now, unfortunately, who have 9/11 related cancers. And so the trauma of that is now getting re-triggered by this, you know, new disaster. So, you know, I think those are the things people are dealing with without access to their coping strategies, right? They don't have access to their support groups or their families like they did before. And so a lot of our conversations are around identifying alternative coping strategies that are feasible in, you know, in the context of COVID-19.
Great, thank you, Kelly. How do you all see the sort of impact on caregivers? You know, we think often of our patients, and then we think so much of the people who are their closest supports. You know, that's also rapidly changing as we see sort of staff drop away in so many different types of programs, including home care, including nursing homes, where we're looking at shortages. Sometimes up to 40% of staffing is absent in nursing homes right now. What impact do you see on sort of those extended networks that are so critical for supporting patients, especially, again, thinking about sort of the older adult with severe mental illness who's also grappling with cancer, where those key people can sometimes make the difference in their treatment? Has that become an issue that you're seeing?
I mean, I think one thing that has really stood out for me, and I know Kelly and your group think about this a lot, but the difference in the different types of caregivers and how COVID is impacting them has been really stark, in the sense that for people who might have paid caregivers who come in and assist with daily, you know, activities, right? These are people who are essential workers. They're on the front lines doing all of the work, exposing themselves potentially. So the stress of that, you know, in addition to worrying about their families, and then the family caregivers of the people receiving those services are also extremely anxious about, you know, my mother needs home health aides. They rotate throughout. She's being exposed to all of these different people. I know they're being careful, and I trust them, but this is still really scary. And so I think, you know, it's different for different types of caregivers, which makes sense, but in a very sort of acute and intense way now. And then there are services that older adults don't have access to. And, you know, the panel was talking, as we were thinking about this, about, you know, people aren't getting services like physical therapy because those aren't necessarily considered essential right now. But what are the long-term impacts of that on an older adult with cancer, with serious mental illness, with comorbidities in the long term? And that's something else we're going to have to think about.
Yeah, I think that's a great point. It sort of leads into my next question, which is sort of think sort of non-traditionally about what types of services we can offer in these times. So much has gone virtual, I think, in terms of telehealth and check-ins and support groups. And can we think creatively about how to extend that to things like physical therapy or occupational therapy? You know, often I think the technology can be a limiting factor for an older adult in terms of comfort level. How has that gone? You know, I think what we've seen in the outpatient clinic at Mass General, just in terms of geriatric psychiatry, is that telehealth has been really embraced, that sort of a lot of people are actually utilizing it more successfully than I think, you know, sometimes the providers themselves, and that can make a real difference in terms of remaining in contact despite sort of the impact of the social distancing and the changes in care. How successful do you think about virtual contacts in terms of non-traditional types of healthcare? Like, how have you seen it work in your settings?
I would say the same thing, where I've been really pleasantly surprised at how well it has gone. It could be much worse. And that's one thing I kind of wanted to highlight or bring up, because I do think there's a lot of negative going on with the COVID, and it's incredibly stressful and anxiety producing. But I do, hopefully a year from now, we'll look back and be surprised at the fact that, oh, telehealth may stick. That would be amazing if we could actually move this forward, because it's, particularly in Boston, much more in New York as well, it's hard to come into the cancer center. And so for some of my patients where it's like a yearly check-in, this has been a huge blessing for them, where I can just call and check in and they can do their labs close. And so there's been a lot of things about the health system where it's pushed everyone to become more efficient. And I hope that that sticks. And so that's where I feel like if there's going to be some good news, or hopefully try to shine some light on this, then hopefully we can have continued improvement in our telehealth availability, and then making everyone more comfortable. Because you're exactly right. I would argue that most of us providers or clinicians are less comfortable with it than a lot of the patients and their loved ones. And then hopefully when things kind of get more back to normal and the older adults can have their children come and even help them further, work with the iPad and use that. Because we have been trying to utilize having people with their iPad and have physical therapy calling into the home. That could be another huge benefit, where people don't have to come into Boston to see physical therapy. Maybe you could be doing that at home and having them coach you through a normal physical therapy process. That would be incredible.
Yeah, no, I think that's great, Ryan. I think maybe it's worth noting also that there have been major changes in terms of regulations around telehealth, from the Centers for Medicare, Medicaid, and sort of pan-insurance panel, allowing sort of everything from WhatsApp to FaceTime to count as contact with patients. And I think that really liberalizes our abilities to reach people in really difficult.
I mean, they actually said whatever works.
Right.
And I was like, oh, I'm sorry. It's what I've been saying for 10 years. Thank you. Let us remember. And let's bring this up when Senator Friedman comes. This is something we don't want to lose. We don't want to lose phone reimbursement, because it's the people who need us most that only have a phone.
Right.
It's more complex. It takes more time and more skill for me to be able to assess someone on the phone. Let us not penalize.
Totally.
Absolutely.